And I'm sorry to bore people because last time I was here, I also talked about parvovirus. So today's case, yeah, from Atlanta, Georgia, pediatrics, is an unusual complication of parvovirus B19 infection in a child with sickle cell disease. And my objective is to present a case of an unusual complication after a recent parvovirus B19. So the last time I came, I talked about we had what we thought was a little cluster of 4 cases of parvovirus B19 and one suspected case in a child who presented um, in cardiac arrest and had a huge spleen. And then a couple weeks later, her brother was found to have parvovirus. So we suspect that she did too. Um, by the end of the year, we had up to 40 cases, which was 4 times higher than our past incidence. So the graph at the bottom shows that since 2010, we were able to look through EPIC using the slicer dicer activity and found that we had some peaks. We had some peaks around 2019 and maybe 2014. We had very few cases during COVID because people just weren't exposed to each other. And then in 2024, we've had this really larger number of children in our hospital getting parvovirus. And it hasn't gone away. Q4 had several, and we still are having at least, 1 or 2 a month. So our recent case started in March of this year with a 9-year-old boy who had hemoglobin S beta plus thalassemia and a baseline hemoglobin of 10. His past medical history included acute chest syndrome once, splenic sequestration 4 times, some of them requiring transfusion. And he developed parvovirus B19 aplastic crisis with a hemoglobin down to 6.5. He also had severe pain, bilateral acute chest syndrome requiring PICU management, and it was called complex and severe because it wasn't getting better quickly. He had persistent fevers and was on a number of different antibiotics. He was also determined to have splenic sequestration based on an enlarged spleen on ultrasound, and it was heterogeneous in appearance, which was consistent with some of it being infarcted. So his antibiotics included levaquin, vancomycin, linezolid, and he was transfused a total of 3 units during his admission, treated with BiPAP, dilaudid PCA. Pain was very difficult to control, so he also got IV ketamine, cocaine infusions. He was treated for a total of 18 days. Less than a week later, he was readmitted with fever, chest, and shoulder pain. His hemoglobin on discharge was 8.8 and had come down to 7.9, but he had some retics. His chest X-ray appeared improved, and so he was treated with ampicillin, ibuprofen, oxycodone, and intermittent morphine. And that hospitalization was shorter for 5 days. Then 6 days later, so this is like a couple weeks ago, he was readmitted with continued pain, which was localized to his left upper quadrant and sternum. He had a new fever, his appetite was low, his hemoglobin was slightly lower than last time at 7.3, his reticulocyte count stable, kind of low stable in the 90,000 range. His chest X-ray, the very first chest X-ray I'm showing on the far left was March 30th. So this was like in the previous admission, but we can see that there's streaky or patchy findings, and the left hemi diaphragm is elevated. When he comes in on this time, it's April 9th now, so it's like 10 days later, and the hemi diaphragm is much higher, and the streaky opacities are still present, maybe a little bit compressed, and there was some on the right-hand side. And then when they looked at his abdomen, there's a very, very large, like a football in his belly, if everybody can see that. And it's causing him to have some scoliosis, and they felt that this was an enlarged spleen. So it definitely wasn't that big in the previous admission. Okay, so next, he had a CT scan. CT scan showed a splenic pseudocyst with necrosis. So I couldn't copy like a whole movie of this without showing his name. But on the left panel, we see the liver. And next to the liver, we see a fluid-filled structure with a rim on it, and that's his spleen. And it pretty much looked like this from the diaphragm all the way down to his pelvis. The only difference was down in the pelvis, there was some kind of debris and kind of some mixed tissue. So that probably was kind of the necrotic tissue kind of falling to the bottom by gravity. So therefore they said, oh, this is not normal, this is bad, and he was febrile. So he had red cell transfusion to prepare him for percutaneous drainage. The culture from this liquid did grow methicillin-resistant Staph aureus, so he was treated with some antibiotics, including daptomycin, then changed to clindamycin. His acute chest syndrome was somewhat worse, so he was treated again for that. And then on this side, on the right-hand side, if you can see, I don't know how well you can see it, but there's a white thin line. That's the needle going into his fluid-filled organ to remove the fluids, and it was drained. So he's now discharged. The spleen has not it hasn't reaccumulated, so that's good. And an elective splenectomy is planned in about a month or so after he's recovered from the current acute chest syndrome. So I want to stop and ask, has anybody seen anything like this before?
This is Julie. I have not. I'm curious why they called this a pseudocyst, though, and not an abscess, if it grew pus, or if it had
Yeah,
pus.
I guess. Yeah, I don't think they drew back plus, but it was culture negative, of culture positive. So I think the pseudocyst was the radiographic diagnosis. But yeah, I think in other places in the chart it was called abscess.
Just curious.
Yeah, so in my almost 40 years of clinical work, I have never seen one of these. So I thought that's why I would share it with you all today.
That is
Okay,
interesting.
yeah.
As is the number of parvo cases you've had.
Yeah. Okay, so let's go back to our parvo cases. All right, so what are common complications of parvovirus? So painful episodes, acute chest, hepatic sequestration, splenic sequestration. I should have said severe anemia is at the top. I'm sorry. Nephrotic syndrome, meningoencephalitis or stroke, and bone marrow necrosis. And so some of the things that we've seen in our local series is our median hemoglobin drop was 3.6 grams per deciliter. 78% received red cell transfusions. I don't know if it's another, but 78% also had pain. And we did notice that some people who had pain had very severe pain. So it would often be these kids who don't get pain very much, like S beta plus, SE. Some of these kind of milder kids who'd never experienced pain before come in and have the worst pain of their lives and are really hard to treat, sometimes need ketamine, and then often get labeled as extremely poor coping. And whenever I hear that being said of someone, I said, go get an MRI. That kid probably has bone infarcts. And they might have parvovirus if you haven't diagnosed that yet. So 27% developed acute chest syndrome, 11% in the series had splenic sequestration. Only this one guy had this particular version. 4% had stroke, 2% had nephrotic syndrome, and there was the one death in the suspected infected case. And we were able to put together our series up until end of September as an MMWR report before poor CDC respiratory probably got closed down. So let's see, what else do I have? So my take-home points for today is that in 2024 in Atlanta, there was a fourfold increase in incidence of parvovirus B19 infections in our patients with sickle cell disease. Splenic necrosis and pseudocysts are uncommon sickle cell complications, so that's why I thought it was worth showing. And the most common complications of parvovirus B19 are severe anemia, severe pain, ACS, and splenic sequestration. And so bone infarcts, we haven't gone through and asked how many people had that per se, but then also long-term complications can include nephrotic syndrome and kidney damage. So that's another thing to keep an eye out for. And if you have any questions or comments, feel free to communicate with me.
There's a couple of questions in the chat. The first was, what about pancreatic enzymes? Are they elevated?
In this guy, I wasn't involved in his care, so I didn't run his labs every day, but I did not see that they were elevated. But that wouldn't be surprising though, right? Because this giant thing is sitting on all your other abdominal organs.
And there's another question from Dr. Aurora. Is he vitamin D deficient? There was research with Dr. Hankins at St. Jude about low vitamin A and D being more susceptible to having prolonged parvo or parvo complications.
I don't remember what his was. We can go back and then actually one of when we're doing the series that includes the entire year's worth of patients, we are looking at that. So I think someone in our group was aware of that. So I don't know about this particular gentleman.
This is Ben here. Very, very interesting case. So you say that they drained this, what I would call abscess cyst. After they drained it, was there a significant spleen left, or was this partly just necrotic spleen? The thing looked so big.
The follow-up ultrasounds showed basically no tissue left. They didn't really show much, so that's why I didn't photograph them for you. But yeah, it kind of completely collapsed basically. So it is felt that that was all necrotic tissue.
That's interesting. Did you also, I'm curious, in any of these cases, do quantitative assessment of parvovirus, like look at number of copies?
Most of ours, so one of our hospitals does quantitative and reports the copy number, and then the other one just says, yes, it's present or absent. So he was at the institution that does the quantitative one, and we haven't tracked that, but we can try making sure we report that, when quantitation was available. We've seen like super duper high, millions of copies, tens of millions of copies.
Yeah, I just wonder about in people with prolonged, whether you should be tracking that. I've heard some people using IVIG, whether that's, I don't think we know if that helps.
Right. I've been kind of tracking the absolute retic count. So, if absolute retic count comes out of the basement and it's kind of, around 100,000, I'm hopeful that they're starting to recover. But what we've seen is that some of the kids stay low, kind of not back up to kind of a robust reticulocytosis for months. So I've had a young lady with hemoglobin SC who used to have a hemoglobin of 11 to 12, and post-parvovirus, she's been 9 to 10 a lot of the time and still kind of symptomatic with pain. And her retics have not, they've taken a long time to recover. And I don't know if we're not full body MRIing them to know like what was the extent of their bone marrow necrosis, for instance.
Yeah, well, bone marrow necrosis though is different than aplasia, which is different than bone infarct.
Yeah.
So, I mean, I think those are all three kind of different things. I've seen them all, but I haven't. My experience in terms of looking for other things were like acute kidney injury. I thought was the complication of the severe anemia, not of the parvovirus.
Mm-hmm. Hard to know. Yeah, we had one guy who had nephrotic syndrome, so I don't know if they ever like stained the tissue from his kidney biopsy to see if they found parvovirus in it.
Dr. Strauss. JJ.
Yeah, where'd he go?
I don't know where he went. He had JJ, do you have a question? Maybe he's just making.
Sorry. I was going to say that people have developed antibody response, especially on bone marrow.
You cut out in the middle. Will you repeat that?
viral loads can be hard because they have low level positivity for so long, often, especially from bone marrow, that you can detect parvovirus for up to a year in people that have appeared to have acute infection.
Interesting. I had heard in several reports about increased numbers of parvovirus in general, not just in sickle cell disease, across the southeastern United States in 2024. I didn't know if it continued. We had a couple of adults affected, but we've never seen it with significant increased pain. I don't know about other adult providers. I actually got a call this weekend about a patient in Maryland who has multi-organ failure with bone marrow necrosis and parvovirus. So certainly something bad out there. And Christy, you're saying you all had a patient with hemoglobin SD who had liver failure from parvovirus?
Yes.
Was that recent?
Maybe a year ago in 2024.
Yeah, so all in that same time range. Very interesting.
But I will say we've had a couple more admissions with eventually fine, because that's the problem. You send the test and then like ours takes like a week or two to come back. And so, you're treating a reticulocytopenic anemia and just assuming it's something of the sort. But I've had more positive parvos in the last year than ever.
Someone named Dr. Alishlash asks if the lungs were included in the CT scan. I'm not sure if they went all about into the lung, but the X-rays definitely they felt looked worse. The 2-view X-rays, and there were other X-rays. The only one I showed was the admission one. So yes, that's why he was diagnosed with worsened acute chest syndrome and was treated for a longer period with more antibiotics.
Really interesting. Does anyone know epidemiologically if there's an understanding of why we're seeing more parvovirus, if it's all related to post-COVID fallout or something else?
The respiratory group at CDC, they also published like their observations in pregnant women and so the OB follow-up and also plasma donors. The sense is that during COVID, when people were not exposed to one another, there was kind of a lot more of the younger kids who were not immune. And then when they went back out and they got exposed, there were just a larger group of not immune people, whereas they kind of usually would be kind of this low level amount of exposure and immunity. So something like that.
That would be my hypothesis. I'm just curious.
Yeah, that's what they were thinking too.
Any other questions or comments?
Yeah, just a comment, a comment on the parvovirus. We have seen it not just in sickle cell, but just across pediatrics. The other thing we saw an explosion of last year was just mycoplasma. So our ID folks have not really told us if they have sequenced it to see if there was a new variant or not.
Yeah, we had that too. We have a graph that looks a lot like our parvo graph from mycoplasma. We had, I forget the total number, but it was maybe like 30 or 40 cases, which was the same as the sum of the last 10 years or something like that.
Wow. I do wonder as well with parvovirus if our pediatric colleagues are more likely to be checking for it than our adult colleagues. I don't know if anybody else has a thought. I tend to check it when I see aplasia, but I probably don't think of it right away.
I had a question. To answer that, Julie, I'll every once in a while, if we have somebody who comes in the adult side and they have reticulocytopenia, I think that's the only indication to check it. Otherwise, I don't think we check it that regularly. But not to open a can of worms, but I'm just curious if, especially with this rising number of cases and then even presumed complications that can result from it, does anybody have any updates on where we are in viral specific T cells for treatment of parvo or even a vaccine? Is this just folklore still like it has been for the past couple decades, or do we know if we're making any progress?
So didn't hear about either of those options from the CDC group, but they're not the only source, of course, of information.
It's a great question. I tend to, you know, it's also interesting, I think, when if I see neutropenia and reticulocytopenia together and they're on hydroxyurea, my first thought is always hydroxyurea, not necessarily parvovirus. So I'll tend
Right.
to hold hydria before I would check for parvo. I don't know what others do, or if we should be checking more often, or if there's a reason to.
One of it's not a pure cutoff, but we've seemed to notice that the largest number of cases seem to have an absolute retic count of less than 50,000. So if you're kind of going super low.
Interesting. All right. Super interesting and super terrifying. Thank you for that, for that case. Certainly, I think we will all be more on the lookout and considering that. Anyway, any last moment questions before we go on to our didactic? All right. Well, I am excited to have I think, fourth year medical student, or maybe fourth year medical student presenting today,
Yes.
for Echo, who is interested in pursuing a career in orthopedics, though I'm sure we would all like to change her mind and highly encourage her to consider hematology. But we are very excited to have her here today, and I will turn it over to you.
Great. Thank you guys so much for having me. Excited to be here. As she said, I'm a fourth year medical student from MCG applying to orthopedics, and I've been doing some recent research on the intersection of hematology and orthopedics. Today, I'll be presenting on the orthopedic manifestations of sickle cell with a focus on its musculoskeletal impact and surgical management. Okay, and so to go over the agenda for today, I'll provide overview of the pathophysiology, common orthopedic complications, management strategies, and conclude with some recent research and key takeaways. So for the pathophysiology,
Lexi, we don't see your slides yet. Are you sharing your slides?
Okay, so I thought we talked earlier and they were going to be, oh yeah.
Okay, hold on one sec. Let's get them up here for you. All right.
Okay, there we go. Awesome. Thank you. We can go to the next slide. Perfect. So you all know the pathophysiology way better than I do. So just briefly, the sickle cell, sickling of the red blood cells disrupts the normal blood flow, oxygenation in the bones, and this repeated ischemia and infarction leads to chronic damage. And the vascular obstruction from sickling is the core mechanism behind the musculoskeletal complications that we see, such as bone infarcts and avascular necrosis. And while sickle cell is primarily a hematologic disorder, its impact on the musculoskeletal system can lead to significant morbidity. We can go to the next slide. So now that we briefly discussed that, we can look at the key orthopedic complications commonly encountered in clinical practice. Sickle cell can affect the entire skeletal system, and the most frequent complications include avascular necrosis, also known as AVN, osteomyelitis, and bone infarctions. In pediatric patients, we may also see manifestations like dactylitis and growth disturbances, which can persist into adulthood. And then I'll now go over these in more detail. So AVN is one of the most disabling and well-known orthopedic complications of sickle cell. It typically affects the femoral or the humeral head, which are particularly vulnerable due to their end arterial supply. Early symptoms may include pain with activity, but as the condition progresses, joint surface collapse can occur. And initial management involves conservative measures such as physical therapy, activity modification, and NSAIDs. However, many patients will eventually require surgical interventions, including core decompression or total joint arthroplasty. In one case, a young adult with sickle cell developed bilateral femoral head AVN in his early 20s. So despite conservative management, he ultimately required a total hip replacement by age of 25. And this highlights how aggressive AVN can be in this population and how early surgical intervention may be needed. Osteomyelitis is both more common and more complicated in patients with sickle cell. These patients are immunocompromised and their bones are already vulnerable due to infarcts. Salmonella is an unusual but important pathogen to remember in this population. The diagnosis can be challenging as it overlaps with symptoms of a vaso-occlusive crisis. Both osteomyelitis and bone infarcts from those occlusive crises present with fever, pain, and elevated inflammatory markers. So imaging, cultures, and sometimes surgical exploration are needed to confirm the diagnosis. A high index of suspicion is essential. For instance, one patient presenting with hip pain and fever was initially managed as a vaso-occlusive crisis, but imaging later revealed abscess formation requiring surgical drainage. And so this overlaps in presentation makes diagnostic delays a real concern. Dactylitis is often the first clinical sign of sickle cell disease in infants and toddlers. It presents as painful swelling of the hands or feet and can be quite distressing, although it is typically self-limiting. Imaging may reveal periosteal new bone formation, as you can see in the bottom image on the right. And this is an early sign of bone involvement. Though dactylitis often resolves spontaneously, frequent episodes should be concerning and looked into further. For chronic anemia in sickle cell, this can lead to compensatory marrow expansion, which can then cause changes in bone structure. And these alterations can affect appearance and function. So you may observe findings such as widened medullary spaces, thinning of the cortices, and characteristic features like the hair on the end skull, which you can see on this top left image. And then you can also see H-shaped vertebrae, which you can see on this bottom left and on this right image. So children with sickle cell may also experience delayed growth and asymmetric limb development. These changes can also impact orthopedic procedures later in life. So altered anatomy or limb length discrepancies may complicate implant selection and alignment during joint replacement. And so surgeons must plan with imaging and sometimes 3D modeling with CT in complex cases. Bone infarcts are also extremely common in sickle cell and can go unrecognized as they mimic infection. Recurrent bone infarcts can lead to thinning of the bone, weakening of trabecular architecture, and osteopenia. Osteopenia in sickle cell is multifactorial, driven by chronic marrow expansion, limited mobility, and nutritional deficiencies. These bones are very brittle and at high risk for fracture, even without trauma. Management of bone infarcts can include conservatory management with pain control and adequate hydration. So for the surgical considerations, any surgical approach for a patient with sickle cell must begin with the medical optimization. This typically involves maintaining a hemoglobin level over 10 and keeping the hemoglobin S under 30%, which they often achieve through transfusion. And it's critical to avoid sickling triggers perioperatively, and multidisciplinary coordination is key to minimizing complications. So surgical planning also involves assessing the degree of bone infarction and previous infarcts, which may alter the fixation strategies that orthopedic surgeons will use. And in some cases, prophylactic exchange transfusion is done in advance, and intraoperative warming, oxygenation are also used to prevent sickling. The most common orthopedic surgeries include total hip and knee replacements, core decompression to preserve joints, surgical debridement for osteomyelitis, limb reconstruction for severe deformities, and fracture fixation. Post-op care for patients with sickle cell focuses on early detection of complications such as these vaso-occlusive crises or acute chest. These patients also require careful pain management and thromboprophylaxis. Early mobilization can help reduce the risk of the vaso-occlusive crisis and DVTs. And if hardware is implanted, antibiotic coverage may need to be extended due to higher infection risk in this population. So sickle cell patients undergoing joint arthroplasty tend to experience higher complication rates. Aseptic loosening and periprosthetic infections are more common due to poor bone stock and altered immunity. Aseptic loosening occurs in about 40% of cases compared to 2 to 10% in the general population, and infection rates are about 6% compared to 1% in typical patients. Sickle cell patients often experience earlier loosening or failure of implants, sometimes within 5 to 7 years compared to the typical 10 to 15 years. Another challenge is that pain perception opioid tolerance may be higher in this population due to chronic pain. which will also affect your post-op management. And so patients also tend to be younger than typical arthroplasty patients, which increases the likelihood of revision surgeries down the line. These patients also tend to have longer hospital stays and more frequent readmissions. So longer follow-up and collaboration with infectious disease specialists are often necessary. To reduce the risk, careful implant selection, antibiotic prophylaxis, and stage bilateral procedures should be considered. So now let's take a look at the current literature, and this goes over what I said before about the differences in the complications between sickle cell and the general population. And so, patients with the sickle cell have poor bone stock, marrow hyperplasia, immunocompromise, and these all contribute to the increased complication rates. So on this table on the right, you can see what I previously talked about with the aseptic loosening, joint infection, prosthesis survival, and the increased revision rate. And a study in 2004 confirmed increased hospital stays, higher costs, greater complication risks, and this further emphasizes the importance of optimized perioperative care and proper implant selection. And you can consider doing a long stem cementless implants and stage surgeries for the bilateral cases in patients with sickle cell. So in conclusion, sickle cell is not only a hematologic disorder, it has significant orthopedic implications. Timely recognition of musculoskeletal complications and careful surgical planning can substantially improve the quality of life for these patients. Ultimately, the goal as orthopedic surgeons should be to approach sickle cell not just through the lens of technical challenge, but with a patient-centered mindset. And advocacy for early detection, multidisciplinary collaboration, and research into better surgical techniques can make a real difference. These are my sources. And thank you for your time today. Very happy to be here.
All right, well, thank you so much for that presentation. Does anyone have any questions or comments?
Hey, this is Sierra from Augusta. One of the things Dr. Kutlar had mentioned, especially in our population, that over half of our patients have ABN by the time they're 30. Is that something that's similar across the board?
So Dr. Cantor had to leave a little early, so let's say, does anyone have any advice for Sierra?
I think it depends on how hard you look. If you do surveillance, I think you do find high rates as people get older, particularly those with SC.
Thank you.
I had a question that perhaps for the group. As we have a new generation of orthopedic surgeons at our institution, some of the younger surgeons get to be rather selective with who they'll consider. They won't do people that continue to smoke cigarettes because of higher risk of failure. They want opiate dose reduction prior to surgery before they'll consider surgery on some patients on high doses of chronic opiates. Is that a pattern that it's not universal at our institution, but I was trying to get a sense of what's happening at other institutions as well.
Hey, Dr. Strauss, at our place, I know we've been, when we've sent some younger patients for consult for hip or joint replacement, one of the things that they always have us work on with the patient is reduction in opioid use before surgery. And I find that I understand why, but it becomes very, very difficult. And then like Lexi mentioned, keeping their hemoglobin above a certain level, it just becomes very difficult to manage. So is it unrealistic expectations? or optimal expectations?
Right. I mean, I think that expect if you say someone has to quit smoking and they haven't done it yet, you're basically saying you're not going to get surgery. If someone's been smoking for 40 years, it's pretty unlikely they're going to pull that off.
Hey, JJ, this is B. Do they require that of all patients who are undergoing surgery or just people with sickle cell disease?
So the opiate reduction is a strategy that is taken for all patients now. They have like perioperative pain management clinics, and that's because people on higher dose of opiates do have not as good of outcomes after total hip replacement. I think that drives that. Smoking's less for me. That clearly does cut across economic lines, at least in North Carolina, pretty strongly. And I think it is a way to risk adjust that patient also having to be without rails, perhaps.
Yeah, it
Right.
sounds like it's a
That's a
way
tough
to exclude our patients. Yep.
that was
Dr. Strauss, I'm not sure if you're speaking, but you cut out after you said that was. Okay.
Can't hear him anymore.
I have a question. Wait,
No.
sorry, B, did you want to finish your thought or question?
Oh, I had a separate question other than that. We see a fair number of kids with chronic back pain who have terrible looking spines, and a handful of them have undergone bisphosphonate therapy. And these are, usually older teens, but I had a kid around 12 get bisphosphonates because his spine, his vertebrae looks so terrible at such a young age. So I was wondering if anybody else has experience with that.
Everyone's so quiet today.
Oh, there's a chat.
Let's see, we have, okay, here we go, a couple people. I've seen the smoking cessation request before. I've also seen ortho requesting dental eval before surgery to reduce the rate of device infection. And yes, there was a really great talk this morning, just sent out the recording. So if you didn't get that and you wanted to see it, then I can forward it on to you.
Sorry, can you guys hear me?
Hello?
This is Sabrina Rainey with University of Louisville. And your comment about the bisphosphonates, um, I don't know the data, but I was talking with, actually I bumped into somebody at ASPO last week who said that he was putting together some data from his experience using bisphosphonates or in sickle cell patients. So I think there may be something that is coming out eventually.
We'll keep an eye out for it. Thank you.
I had a quick question for you, Lexi. So first of all, that was a great talk. Thanks for an overview. My name's Tarun. I'm from Emory and Choa down in Atlanta. See patients with sickle cell in the AYA population. I'm also an MCG alum, so phenomenal school. I don't think we can convince you to go to hematology, but I will say we do bone marrow biopsies every once in a while, and that involves the bone. We don't necessarily fix things with bones, so that's on you. But I had a question for you. Just in your research, if you know, since you're kind of like probably up to date on the ortho stuff, is that there was a great talk at ASFO, which I also attended this past week, and there was a discussion by an orthopedic surgeon from, I want to say somewhere in the Bronx, and he was saying that some of the novel therapies that are out there are like implanting certain types of rods, which aren't super favorable in the sickle cell population because of their high failure rate, but also stem cell. And so I'm very unaware and naive to how that would work in the general population, or more specifically our sickle cell population, but it is something that I think could definitely avoid surgery. Did you read anything about it, or do you know anybody who would have had experience with that?
I don't know anybody who has had previous experience. When I was doing some research, it's very briefly mentioned. I think it's very, very new. So in a lot of the review articles, it's not typically mentioned. So I think that's a very new and upcoming thing. So more should be out later, but there's not a ton on it right now.
Great, thanks. If you do a research here during your ortho fellowship or your residency, now hopefully you have an idea.
Yes, exactly. Thank you.
All right, any other comments or questions? Well, thanks again to our presenters today for the great presentations that you gave and the discussion that it encouraged. So we will see everyone again in 2 weeks. We will be here on Tuesday, May 27th. So have a good week and we'll see you soon. Bye.